Okay. We may have a few more people joining, but I'll go ahead and get started with today's third in this series about strategic communications for health equity related data collection, supported by the Colorado Perinatal Care Quality Collaborative. We can go to the next slide. So I'm Vicki Quintana. I'm a Senior Program Officer at the Center for Healthcare Strategies. I'm joined today in the presentation by Ann Smithy, also a Senior Program Officer at the Center for Healthcare Strategies, and our two colleagues from the Colorado Perinatal Care Quality Collaborative are here, Amber Johnson, Director of Quality Improvement, and Katie Breen, Vice President of Quality and Strategy. So next, I'd like to just go over the agenda for today. We're currently in the welcome and introductions. Next, we'll get into the topic of the day, strategic communications, and start thinking through why this is an important aspect of race, ethnicity, and language data collection. Much of the day will be spent on a workshop thinking through audiences, messages, and building buy-in at various levels. We'll leave plenty of time for question and answer, and then we'll end with some reflection and wrap up. Next slide. If you don't know the Center for Healthcare Strategies, we are a national nonprofit based in New Jersey that works with stakeholders to strengthen healthcare services, particularly for children and adults served by Medicaid. So we work to advance more effective models for care delivery, more efficient policy and program design, and more equitable care and opportunities to address the obstacles that stand in the way of health equity for people facing the greatest disparities. Just a couple housekeeping items before we move into the presentation. We would love to welcome you if you're able to come onto camera and let us know let us know you're there. Feel free to participate in the chat, ask questions, put thoughts, contributions throughout. We'll also have specific times when we ask for your input. And then just a couple other details. If you're calling in, you can pair your phone and video, so you have that one square. We invite you to rename yourself to include your name, pronouns, and organization if you'd like. And at the end of this webinar, as I mentioned, it's the third in the series, so we will have an evaluation. We'd love to hear your thoughts, specifically other things you might want to learn in future opportunities with the Perinatal Quality Care Collaborative. There is an opportunity to get a gift card. So stick around for the evaluation. Okay, a little bit more about this series. The first in the series covered opportunities to improve race and ethnicity data collection. We'll be revisiting some of that content today and developing it further for strategic communications. We also took one of the sessions in the middle to do understanding quality improvement with the health equity lens. All right, so I am going to get into a brief refresher on sessions 1 and 2, just in case you missed them. And I'll also note the recordings are available to you, so you can watch them back if you missed them or if you just like to see them again. But the first webinar focused on promising practices for data collection of REL data. So we went through understanding the role of racism in creating health disparities and how the collection and analysis of REL data can help you in identifying disparities. We talked through the importance of training for staff who will collect data, including scripts and suggestions for how to explain why they're asking for the information and how to deal with resistance. And then we talked through engaging in REL data collection as an approach, as a conversation that can help open doors to improving the care experience overall. In the second session, we went through promising practices for quality improvement with a health equity lens. So we started with disaggregating data on outcomes, process, and experience of care by race, ethnicity, and language, and other data to find disparities. We talked through how to frame QI questions from a systems perspective rather than an individual perspective, focusing on why the system achieves different outcomes for different populations. And then we talked about the approach of curiosity and engaging in quality improvement activities such as root cause analysis, using a fishbone diagram, doing the 5 whys and the 4 corners exercise, and other QI tools to diagnose the root causes of inequities. And now we'll get into the reason for today's session. We'll talk about strategic communications for REL data collection with a health equity focus. And while I'm talking through our reasons and making the case for why strategic communications is a topic in this series, I invite you to add your own reasons. Why do you think it's important to learn about strategic communications for health equity related data? So you can add in the chat as I'm going through some of these reasons. So first, we recognize you have to communicate with many different groups as part of this effort. So if you are involved in quality improvement or part of the staff who's spreading some of these best practices in your organization, you have to talk to other staff to collect, record, and use the data. So you might need some internal messaging about to help staff feel empowered to talk with patients about QI efforts. Of course, patients are an audience that you have. So during their medical appointments or interactions with your system, answering questions about the data. So you may need some messages for patients to help generate trust and comfort and contribute to the therapeutic relationship. And you also may need to be speaking with leadership to gain buy-in and generate support for your QI efforts. So you may need messages to help leaders understand the factors impacting patient care. And we also acknowledge that communication about personal data and health equity can be challenging. So we're suggesting strategic planning can make communication on these topics more clear and comfortable. And this may not need to be said, but since we're going into communication, what we say is not the only thing we communicate. So it's not only the words, but it's also the values and messages that are present in people's minds already, which you may be talking, we refer to that as subtext. So not just what you say, but what you're communicating around what you're saying and the values and messages you're connecting with. So paying attention to this can help ensure that your communication is positive, affirming, and builds trust. So the overall objective for today is to develop and improve messages for collecting and using health equity data. And with that, I don't see any reasons in the chat, but I invite you to continue adding. Yeah, thanks, Katie. Help explain to teams why we are prioritizing health equity related data collection now. Yeah, timeliness. Okay, I'll get into the format we're going to use for today, and then we'll get into some exercises. So the first step would be to start with your audience. Think through who you're communicating with and what are their likely concerns. It can also be helpful to reflect on how you know their concerns. Do you have sources of data for what the people you're communicating with are concerned about? And if not, how can you learn about what their concerns are? So we're going to be providing a framework and also an example throughout this introduction. So in this case, we're going to say the audience is patients who are asked to share their race and ethnicity in a hospital encounter. And their likely concern, they could have many, but one we're going to think about here is, will this information affect my care? All right, so once you've started with your audience and what you think their likely concerns are, then you're going to think through what are the key messages. And this comes from both sides. What do you want them to know? What do you want to tell them? And then also, how do you address their likely concerns? And then once you've come up with something, thinking through what is the clearest way we can say what we want to say in a way that's understandable. So building on the audience of patients asked to share their race and ethnicity data and their likely concern of, will this affect my care? We want them to know that we'll use the information to analyze health disparities and that our goal is to provide culturally competent care. Those may be two of the things, there could be others too, but these could be two of the top line things that you want to try to communicate. So one of the key messages you might come up with, it could look like this. We ask about race and ethnicity because studies have shown bias can impact care. We review the treatment patients receive and make sure everyone gets care that meets their needs. So you want to check that this is clear and that it says what you want to say and addresses concerns. And as we keep building, we'll keep evaluating this key message. All right, so next step is to think through what are the opportunities to deliver the messages? When does the audience need this information, and what are good ways to tell them? So sticking with the example we're building already, opportunities to give the message could be at check-in, on the registration form, or when talking to the clerk, or there may be a self-service portal that you're using for registration or check-in. So those could be opportunities when it comes up naturally. You could also think about having these messages in your back pocket whenever a patient asks about why they were asked for their race and ethnicity, or if it comes up, a quality improvement project that you're working on comes up, or health equity as a topic comes up. So those are other opportunities that you might have to give the message. Okay, you can go forward. Okay, next is what we talked about a little in the introduction, thinking through our message with a little bit more of a critical eye towards the subtext. So thinking through what's in the subtext, here are some questions to help you evaluate. You can think through what values are we communicating with our key message? Are these values what we mean to be communicating? Or do we need to adjust our messages to align with our values? And this is a little bit different. It's a different way to think because you do have to get a little bit underneath what you've said and think about what you truly mean. So for example, we can break this key message apart a little bit. We ask about race and ethnicity because studies have shown bias can impact care. So one thing that you're communicating there is we're aware that we could be biased. And that is, if you think about what value you're communicating when you're saying that, we're aware that we could be biased. What you're saying is transparency. You're communicating that you want to be transparent with the patient and let them know that you're aware there could be bias. And then the message, we review the treatment all patients receive and make sure everyone gets care that meets their needs. There's sort of two things we picked out here. So what you're saying is we really want everyone to get the care that meets their needs. This is an equity message. This is what you need. We want to provide it. We want to make sure. And then there's also an implicit message, I think, here, which you're saying we care how you receive our care. We care how it affects you. We care that we do this well, which the value that's communicated there, one of them is compassion. We care about you and we care how you experience us. Okay, let's keep going. The next step you can think about is there resistance that could be present? And there's a spectrum of resistance, right? There could be sort of a mild, like, I don't really like this question, but I'm answering it for you because you asked. There's a lot surrounding that. Maybe it's power dynamics. Maybe it's, a feeling of respect, wanting to respect the authority of the person who's asking, or just not wanting to, make waves. Or maybe it is concern about how the answer would be received. And then there's outright, there's more apparent forms of resistance as well. You might hear a counter message. You might get questioned about why you're asking these types of questions. And then there's also messages outside the room, present in our common culture, our social environment, that might be sort of informing responses and resistance. So this is also a complicated task, but thinking through what is the resistance? Are there counter messages? Are there common concerns or opposing messages in the media? So for example, with our key message here, the potential resistance could be, you don't need this information, just treat everyone the same. In fact, we hear this a lot from even within the community of people who are aiming to provide equal care, that fairness and equality are actually the goal. And equity is a slightly different goal. Making sure everyone gets care that meets their needs is slightly different than everyone getting the same thing. So this is the underlying value here is fairness and equality. And then there could be even more resistance, and there is an opposing message in the media that there is not a problem with bias and that bringing up bias is the problem. This is sort of the anti-woke sort of messaging that we hear. So talking about bias is woke, and there's such a thing as individual responsibility rather than system responsibility for differences in outcomes. So this is a counter narrative that comes from the underlying values of individualism or personal accountability. There could be more, and there could be different interpretations of these values, but engaging in attempting to understand some of the resistance that happens, and then what values underlie the resistance can help you move forward and tailor your messages. So then the last step is how do we address resistance? And there could be a menu of options here too. You can choose not to. You can choose to stick to the message you've created, but you also have the option to think through whether the values that you hold are inclusive and can be inclusive of the values that underlie the resistance. And this could be more effective actually to getting buy-in and bringing people over to understand, especially if the resistance is a little more on the curiosity side, and they just need a good reason, something to buy into. So if your values are inclusive of the values underlying resistance, then it's possible to adjust the message or add another message to address those values. So you can see here the bold type on the left-hand side under key message are the new additions. So we ask about race and ethnicity because studies have shown bias can impact care. We review the treatment of all patients receive and make sure everyone of every background gets the highest quality care that meets their needs. And the phrase we added there is everyone of every background gets the highest quality of care, which incorporates the fairness and equality value with the values we were already communicating of transparency, equity, and compassion. Another option would be to add an additional message. For example, we want to provide everyone the best care possible, which also speaks to fairness and equality. And this message, this last one, it may or may not address the resistance raised, but if it feels true to say something that's aligned with your values, that somewhat touches on the values of the resistance, that can also be a good way to go. So for example, if someone is presenting some resistance and saying you don't need this information, there is no bias. The way to ask could be, well, we record this information. We prefer to record your race and ethnicity based on how you define yourself, which gets to self-determination as a value, which is not the same as individualism or personal accountability, but it is closer than what we had before. So that could be a way to go also. Okay, so I'm going to summarize a little bit of these tips, and I'll pause then. Feel free to put questions in the chat if you have them already, and then next we'll transition into the activity. So hopefully something you're seeing and can use in the messages you develop going forward. For any purpose or audience, strong messages have these things in common. They're relevant, which includes timely, delivered at the right time and tailored to the audience and their needs for information. They're concise, using fewer words if possible is good. Compelling, which also can get to relevance. It addresses the information that's needed, and clear and easy to understand. They can be debatable. That you can have someone who doesn't buy into the message, but it should be clear and easy to understand. And then thinking through when and where messages are delivered can make them more effective. Thinking through who delivers them and what supports they need, of course, is a good practice. And also, you don't have to stick with the same message for the same effort. They can be updated and refined as needed based on the feedback from staff and patients. And then when addressing resistance, it's helpful to use non-judgmental language and affirm the concerns that people raise. So for example, you could say, lots of people feel the way you do. I understand why you feel that way. Our unit or our floor has experience supporting patients with similar concerns, or other things that help validate the resistance that's coming up. So I'll pause here for a minute and see if there are any questions before we move into the activity. Okay. You can keep putting questions in the chat if they come up, but at this time, I'll hand it over to Anne to walk us through an activity.
All right. Thanks so much, Vicki. So yeah, Vicki presented kind of a number of steps for thinking through identifying an audience, building a key message that's tailored to them, and thinking about the subtext, both in what you're saying to your audience and in what they might be saying back to you. So we're going to take an opportunity to put those steps into practice today with two different exercises that I'm going to lead us through. So far in much of this series, we've been talking a lot about speaking with patients, in particular when you're working to gather information about race, ethnicity, and sometimes preferred language from them. But it's also important to think about the fact that all of these efforts we've talked about, collecting the data, analyzing the data, using the data to do quality improvement activities that focus on health equity and health disparities, also requires buy-in from your colleagues. You might need buy-in from clinical staff, from administrative staff, and from leadership to kind of change workflows, find ways to store this data in a way that's private and secure, take the time required to analyze the data and use these QI tools in the ways we talked about in our second session. And so we've spent some time talking about communicating with patients, and these two exercises are really going to think about framing messages for the audience of your colleagues. Thinking about concerns they might have, like changing workflow, limited time, and uncertainty about the effectiveness or impact of this kind of work. So I'm going to introduce the first exercise, and then we're going to pull up the Zoom whiteboard to give us a chance to make it a little bit more interactive. So for this first exercise, we're going to imagine that we want to ask the clerks or the administrative staff or intake staff who record birth data to start collecting and recording race, ethnicity, and preferred language data, both from the person who's giving birth and, if they're present, that person's partner. So we've started with our audience, right? The people who are recording birth data. We've started with the basic message we have, which is we're going to ask you to add something to your workflow and start recording, collecting and recording this data. And so now we'll use the rest of the exercise to think through some of the steps Vicki talked about around addressing concerns and thinking through values. So I will stop sharing my slide. I'm going to have Vicki pull up the whiteboard that we can all contribute on. I see it's loading. So if you haven't used the Zoom whiteboard before, it's fairly straightforward, but I'll give you kind of a quick walkthrough of how to do it. First, if you need to zoom in or zoom out, there's buttons on the lower right-hand corner that can help you do that. Also down there, you see at the far left of the toolbar on the bottom right, a hand. You can click the hand to grab and move your screen around. So what we'll do together is walk through each of these columns and get a sense from you all what you think, each of the steps we walked through. So to add thoughts to this board, you can go on your left-hand side. There's a toolbar that has a cursor arrow at the top. And second from the bottom, there's a square that looks like it's being peeled back. That's a sticky note. You can click that to add a sticky note. You select your color and you start typing on it, and you can place it in the columns. So what we'll ask you to do is first take a moment to think through, and Vicki, this is actually the second whiteboard. Can you pull the first one up? Just realized. Sorry about that. We have two exercises, same looking whiteboards. Okay, so what we'll ask you to think about first for this audience, people who are recording birth data, who we want to collect race, ethnicity, and language data, add into the far left-hand column on this page, what do you think their likely concerns might be? So I'm going to give you all a moment to do that, and then I'll share some of your thoughts. If you have issues finding the sticky notes or adding thoughts, please also feel free to throw things in the chat itself for the Zoom. You can send it to the whole group. You can direct message it to me or Vicky, and we can share it with the group on your behalf. But don't let technology stand in the way if that's a problem. Great. So seeing some comments already. I see one around, it might be additional workload. People might be worried about offending the patient or the partner by talking openly about race and ethnicity, something we're kind of by society trained not to do, and it can feel really invasive at times. People might be thinking, what's wrong with what this hospital or birthing center is already doing, that you need to collect this data? You might be unsure how to ask patients, or the people you're asking to do this work might be unsure how to ask patients. It might be the case that there's a lot of different people to educate in your staff who you need to kind of prepare to give this, and the people who would be collecting data just feel like there's too much to do to get ready for this effort. A person might be concerned that a patient has a follow-up question they can't answer. A patient might have specific concerns like immigration, or other concerns that they don't want to share with staff, and the staff don't know how to answer it. All right, so those are all great answers. I think that's, covers the gamut, right? Things from workflow to communication struggles and difficulties to worries about kind of damaging the relationship, the therapeutic relationship with the patient. Okay, so we've thought about the audience and the message and their concerns. Let's think about what opportunities, we'll come back to the concerns in just a moment, but let's think next about what opportunities we have to deliver this message. So again, in this case, we're not talking to the patients and speaking to their concerns. We're talking to staff who are collecting this data and who have shared with us these concerns. When might we talk to them about what we're asking them to do, and when might we have an opportunity to address some of their concerns? So go ahead and add some stickies into that second column. All right. I'm seeing a lot of answers coming in. I'm going to give it another moment for people to finish up what they're typing. So it might be helpful to share in multiple formats: emails, newsletters, unit meetings, town hall meetings with the whole hospital or organization. It might be helpful to do this both in bigger formats like staff meetings and in smaller ones like one-on-one conversations where you can maybe get more specific. You might do it in signs in the bathroom, a place where everyone's in there all day, washing hands, taking their time. It's a good opportunity. You might do it during onboarding, making it feel like it's part of company culture and sort of a default option as new staff join. When you're thinking about opportunities to deliver the message, you might think about opportunities you have to explain the why, not just the what. It could be ongoing opportunities, making sure education isn't a one-off thing, but something you're doing consistently, frequently to make sure staff feel comfortable with this new role, and have an opportunity to bring up new questions and refine your messages over time, like Vicki said earlier. Make it a team effort with some kind of big kickoff meeting, kind of making people feel excited and ready to get started and like we're all in this together. I love these really great suggestions and really display that there's a lot of different ways we can share messages. And like Vicki said earlier about tailoring to your audience, it also makes sense to tailor to your opportunities. We've seen a lot of examples where people have kind of put together training and slideshows and things that you can refer to over and over. But it's also good to have these kinds of conversations where you can get more in depth and more tailored to the person you're talking to and their concerns. All right. So next, we have our audience message. We know their concerns and we've thought about when and how we might deliver this message. Let's think about what values you want to communicate to staff who will be collecting race, ethnicity, and language data. What do you want them to know and to feel when you're asking them, we're asking you to change your workload, we're asking you to take on a task you might be concerned about, but here's the values our organization has, and here's why we're trying to do it. Okay, so the value of improvement, continuous quality improvement, the value of using the work you're doing for the good of the patients, for the greater good of the organization. The value of being based on evidence and being scientific, thinking about collecting data and understanding problems. Oh, I really like this one. We want to give you the tools you need to do this well. Your value might be that we care about staff and we know we're asking you to do something new and something you might be nervous about, and we will train you and we will work with you to make this process work well. We care for you. We'll give you the tools you need. Patient-centeredness, that we're here fundamentally to take care of our patients and that this new effort we're doing will be valuable to them. So lots of values we want to communicate. And we hope that these values help address likely concerns of the staff we're talking to, right? When you're sharing values like we care about training you adequately, we care about improving outcomes for patients, we care about looking at evidence and understanding data. Those are some things you might be addressing, some ways you might be addressing their likely concerns. But we still know that resistance could be present. So are there any other points of resistance, either based in the values you just raised, that you would raise, or do you think we kind of captured it all already with the likely concerns column? Feel free to add more if there's more points of resistance that you can think of. But if not, I think we've got quite a few in our first column as well. More charting. Yes, a very good point of resistance. Defensiveness about the existence of implicit bias. Concerns about what it might say about the hospital or the organization or the care we're providing if this data finds disparities. Concerns about feeling like you're being told you're providing poor quality care. Will what's happening federally impact this effort or harm it? Sort of in general, how does the external environment come into play? People might say, I'm personally fine with collecting this data, but I worry it will open us up to harm, open our patients up to harm. It's a really important one to consider as well. All right. And last but not least, let's think about what we can add to our message to address the likely concerns you raised at the beginning and the resistance that could be present. So think about the values you want to communicate and consider kind of if there's anything you would add to this message, the message being, we'd like you to start recording and collecting and recording REL data for the person giving birth and their partner. And what are some things you could add to help address concerns among staff? Feel free to keep writing it on the sticky note. This might be a little bit longer, so if you want to come off mute and share verbally some of your thoughts about what you'd add to the message, please feel free to do so too. We love hearing your voices while seeing your typed words.
Somebody kind of already said this, but we could add to the message something about how like we are planning to like provide the team with as many tools and resources as possible to make this easy and sort of remain open to their feedback about what would make it easier.
Great. I like that, Katie. So you're not just asking, you're asking and immediately following up with, here will be the training opportunities, here will be the resources, making sure people are familiar with that from the get-go. I think that's similar to the sticky up here about change taking time and support, making sure we're clear in our initial message that we know it might take a while before we're perfect at this and that it's a process, not a, one day everything's perfect, and that we're willing to listen to feedback. As healthcare providers, we have a responsibility to measure and evaluate the care we provide. This is where we start. I really like that one too, thinking about our roles and our responsibilities, getting to the values of caring for patients and using evidence we have, making the case for why it's valuable to spend time on this, even though it does mean potentially more charting or it might mean a change in workflow. All right, so I also wanted to share a few examples from an organization that's done this before. I looked at training materials developed at Northwestern University for their efforts to collect race, ethnicity, and language data. They put together a slide deck that can be used in a bunch of different settings, targeted both at kind of staff like this, clerks or registration staff recording data, and hospital leadership. And they were really getting at the concern of kind of why should we bother doing this? So they put together key messages about the importance of effectively collecting data to meet state laws and quality efforts. I think you guys can relate to that here in Colorado. And they wanted to, provide training that would help explain why the data was being collected, how to do so, and answer some questions. When you kind of looked through the materials, we saw a lot of the values and subtext you all brought up. Desiring to provide fair, equitable, and better care, and caring through staff through adequate training. And something they did, which we already addressed in our first webinar in this series, and as Vicki mentioned, you can find recordings of those from the CPCQC team. Will be posting and sharing those, is that we can provide scripts, we can provide FAQs, and they also provided data from their own hospital that showed that patients agreed that collecting REL data was valuable and would help improve care. So they kind of got at 2 points, right? The data collection piece and the concern about how patients will respond piece. So just wanted to share that as one example of a place where this has been done. In the kind of notes for this presentation, which you'll be able to get from the recording, we'll share some of those materials from other organizations that have done this training. And that can help you, these steps can help you think through how do they effectively communicate about the work they're doing. All right, so we'll pull up one more whiteboard. We're going to do a similar activity. We'll walk through it a little bit more quickly this time because I'm aware of time. But it's really thinking about the next step beyond race, ethnicity, and language data collection, which is how you use the data. So for the next activity, we'll think about you're communicating with departmental leadership who need to authorize a QI effort that you have come up with and need to be involved in future steps. So you really want their buy-in. And what you're thinking, what you're trying to share with them is that our data shows we perform more potentially unnecessary C-sections on Black and Asian people compared to other races. And we'd like to test out a new checklist to help providers determine if a C-section is unnecessary or necessary, which we hope will decrease implicit bias in making recommendations for C-sections. So for this example, we're just going to do the first column and the last column. So first, think about what might be the likely concerns of your leadership, your department head, your C-suite around testing out this QI initiative that you're proposing. What might they be worried about? I really appreciate the one up here about will identifying disparities make the hospital look bad. I think that's a really big concern of organizations when they embark on health equity work. is, are we basically admitting that the quality of our care isn't as good as we hope it is? And I think that's one that's really important to consider and think about how you can address, which we'll talk about in just a moment. Some other great contributions up here, concerns about added workload, concerns about sort of developing, validating, and managing a new checklist, publicly sharing data, concerns about the cost, time, and resources needed both to kind of get this up and running and then run this program, concerns about offending providers and staff by talking explicitly about disparities in care, concerns about completing the form, making sure things are actually used. I think these are all really great contributions. All right, so now, like I said, we're gonna zip through it, not in the optimal way, but recognizing time. And we'll do the last column now. What can we add to our message to address some of the concerns and resistance that you all just raised? So again, feel free to put it on your sticky notes. Feel free to raise it verbally if you'd like to as well. But how can you think about addressing concerns around resourcing, getting staff and providers bought in, identifying disparities and the risk you might be opening your hospital up to reputationally? I'll share one example while you are all are thinking from a different project Vicki and I work on called Advancing Health Equity. We were working with a health plan who was kind of trying to make a case similar to this one to their leadership. And one of the things they really emphasized is about how equity work fits into the pre-existing quality improvement framework that the organization already used. They tied it to organizational mission and vision and were able to say, you know, these quality organizations are all saying there is no quality without equity. You know, we've listened to them all this time. Why would we stop listening to them now? Something else they brought up was talking about that disparities are a part of low value care, and that if you value efficiency and effectiveness of care, paying attention to disparities in care is one part and parcel of that. Up here are some contributions from you all showing that we care about bias and disparities is what makes us a great hospital. I really appreciate that too, kind of going back to one of Vicki's earliest points about the value of transparency. Communities know what's happening. People know that health disparities exist, and showing that we care about it and we're interested in working on it can actually build a reputation and can show that we are good at providing care and that we have compassion and care for our patients. It's a standard of care, thinking of this not as an add-on, but a necessity to providing high quality care. I'll give it just one more moment. Any other thoughts about how we can add to our message to address resistance? I have one more around sharing data publicly. When you're talking to leadership, you can talk about, well, we decide how we frame the data we share. It's not, you know, you're not going to publish a report with no vetting and no thinking about it. So we can mitigate some concerns around how do we frame it? How do we practice these strategic communication rules to show our values of compassionate, high quality care? Definitely financial improvements when organizations, providers are being graded on quality of care. People experiencing the greatest disparities are kind of making it so you can't earn those quality bonuses and reimbursements. Addressing disparities, addressing the outcomes that are the worst among patients is good for the patient and it's good for the organization. All right. Well, thank you so much, everyone, for your contributions and cooperations. I think it's really helpful when we're talking about something that can be as nebulous as communication strategies to put it into practice and to think through how you would apply these skills and think about values in a somewhat real setting. So thanks so much for your thoughts. I'm going to share it with Vicki, or I'm going to share my screen and pass it back to Vicki for a few more words. here one more example we wanted to share with you all.
Thanks, Anne. Yeah, we just wanted to, this is actually pretty recent data that's out about the Massachusetts Maternal Equity Safety Bundle. So we wanted to share some of the key lessons for applying an equity lens to QI projects. And this was one of the explicit goals of this Maternal Equity Safety Bundle. So just for a quick background, getting on the same page, a safety bundle is a group of practices to address the leading causes of maternal morbidity with QI methodology. And practices included in the bundle are staff training in anti-racism, some best data collection and analysis practices, evidence-based processes for care delivery. They also developed a toolkit and technical assistance for implementation. And they did show some reduction of racial inequities. So the results we want to uplift are from focus groups conducted with nurses, residents, and attending physicians. And they described some of the key facilitators for implementing the bundle. So they named knowledge of state and national inequities in maternal health outcomes as one of the things that helped them to implement the bundle of resources and practices. So knowing about their local context, their state context, as well as national inequities in maternal health outcomes helped them to generate the support needed to implement these practices. They also identified paid and otherwise supported staff time to engage in training activities and QI efforts. And that's equally as important as anything else. You need to be supported and participating in these efforts. And last, one of the huge things that came up was a culture of equity, accountability, and quality improvement, which is broader than us as providers and our individual competencies, but really systems level practice change and culture change for the entire organization. So I'll lift up some of those key features of this culture of equity they described. First was leadership commitment and consistent communication of equity as a priority. They also talked about being able to address resistance with a strengths-based approach that encourages questions and conversations and creates a supportive environment for people to learn and improve. They had a lot of interdisciplinary collaboration and communication across professional roles and involved trainees in equity projects. They implemented robust systems for self-reporting of REL data and other demographics, focused on accurate data collection and analyzing REL data across maternity projects. And this culture of equity, they defined it as one that provides individualized, evidence-based care that accommodates each patient's needs and preferences while acknowledging existing inequities and fostering a sense of belonging. So I think the main point we want to make about this bundle is that it takes a set of practices and continuous communication and collaboration to really make the impacts you want to make on racial inequities in care. So their key finding, one of the key findings was that collecting and stratifying data by race, ethnicity, and language was a huge success, and it was part of all of the efforts that they undertook. So broadening the lens a little bit there. And that's really the last example we wanted to highlight. Next, we want to turn it over to you all for questions and answers, and you may have some of the answers too. And then we can go through some takeaways after that.
Great. Thanks so much. So yeah, we really want to take some time here at the end of this series to hear a little bit from you, a couple of things. First, do you have any questions that we can help answer from today's session? And then second of all, can you share with us anything that resonated with you that you'll take back to your organization, and in particular that still feels challenging to you? As a reminder, the point of this webinar series is that you all are now required by state law to disaggregate quality data by race and ethnicity and share it with CPCQC. And we know this is a challenging task, but it's also one that it's really important for you all to feel that you have the tools to succeed in. So wanted to hear from you all, what questions you have and what still feels challenging. And if there are other ways that CPCQC can be helpful to you all as you kind of embark on meeting these new requirements.